Hello, everyone, and welcome to Warrior University. I realized just now I was on mute. I apologize. But welcome, everyone, to Warrior University, and thank you all so much for joining us. We have a very special class planned for you tonight, with a very special presenter. It's going to be great, and thank you all so much for joining us for the Warrior University course, Curative Therapies. It's going to be very informative. Today, we are going over bone marrow, and we are going to be talking about BMT, low intensity versus high intensity. So make sure you have pen and paper to take notes, ask questions. If you have any questions, you can always put it inside the chat. Whether you're joining me from Facebook, YouTube, or if you registered and joining us from Zoom, you are able to put your questions, comments inside the chat, and we are able to see it. So thank you all so much for joining us. It is a pleasure, and we will be getting started very shortly. We're giving people enough time to come in. So thank you guys very much. Don't forget, we also are having three more classes. We are having Comparative Technologies 2 next Thursday, Comparative Technologies 3 on June 22nd. And then we're having a wrap up with Dr. Lakia Daly on all of the comparative therapies on June 29th. So be sure to join us. We are going to be having support the caregiver, managing expectation, patient needs and responsibilities, and the psychological impact, mental health, virtually held during the Warriors Convention this year. So thank you all so much for joining us. This is going to be an amazing class. Once again, we have a great presenter. So thank you guys. Hi, everyone. Thank you all for joining us. If you are joining on Facebook, hello, Facebook world. If you are joining us from Zoom, thank you guys so much for joining us through Zoom. Hi, YouTube. Thank you for watching us. We have an amazing presentation for you today for Warrior University. Once again, my name is Dominique Goodson. I am the Dean of Warrior University, and I would like to thank you guys so much for always constantly supporting Warrior University. We do these classes for you guys to educate the community. And if you have any classes that you would like to see happen, please feel free to email me at warrioruniv at sicklecellconsortium.org. I will put that inside of the chat. Once again, that's warrioruniv at sicklecellconsortium.org. If you'd like to see any classes come to fruition, send me an email and I can make that happen. Thank you all for joining us. We are going to be getting started in 1 minute. Please remember that if you have any questions, please put them in the chat. We are monitoring all chats, so put them in the chat if you have any questions at all. And thank you guys for joining. Once again, this is Warrior University course, Curative Therapies. And this is the second class of the series, and we are going to be talking about Comparative Technologies 1. There's 3 classes on it. 4 classes technically, because we're going to have a overview at the end. So this class is going to be BMT, low intensity versus high intensity. So thank you guys so much for joining us, and we are going to be getting started shortly. Thank you. Hi, everyone on Facebook. Hi, everyone on YouTube. Thank you all for joining us. This class is going to be great, and we are going to be getting started. Thank you all. Come on all in, and thank you for always supporting Warrior University. We couldn't do this without you guys. There will be no reason to. So thank you all so much for supporting Warrior University. So that we have enough time that we can ask questions and a great presentation from Dr. Akshay, we are going to get started. So I want to remind you guys that please, if you have any questions, you can access the chat box, whether you are in Facebook, Zoom, or YouTube. You can access the chat box and send your questions to me, the moderator, or to the entire group. Now, before we begin, the patients, caregivers, and community-based organizations of the Sickle Cell Consortium are delighted to provide Warrior University as an online curriculum-based education module. However, please note, this is a general discussion and is not meant to replace the advice or instructions of your doctor or other healthcare professionals. Statements made are not meant to reflect the policies, thoughts, or opinion of the consortium and do not imply endorsement or recruitment for any product, service, or clinical trial. As a reminder, this class is recorded and will be made publicly available online. Private questions should be addressed to me, Dominic Goodson, or to the presenter, or you could just put your questions inside the chat to everyone. So, without further ado, I would like to introduce Dr. Akshay Sharma. Hi, Dr. Sharma.
Hi, Dominique. How are you?
I'm doing good. Thank you so much once again for doing this for the Warrior University. So, and to save time, we're going to get started. So, take it away, Dr. Akshay.
All right. Thank you so much. And thank you for having me. I'm going to start sharing my screen. Okay. All right. Can somebody confirm that you can see my screen? Is this good? Can you guys see my screen?
Yes, it is. We're good.
Okay, perfect. All right. Well, good evening, everyone. It's really a pleasure to be here. I'm Akshay Sharma. I'm a physician, a transplant physician at St. Jude Children's Research Hospital in Memphis, Tennessee. And today I will be talking about bone marrow transplantation for sickle cell disease. Before we get started, I want to uh, share some conflicts of interest and disclosures. So, I have been a consultant for some companies that are listed over here, some of which are engaged in developing gene therapy for sickle cell disease. We will not be talking about gene therapy today, but I did want to put it out there that I have been a principal investigator for some of the clinical trials of gene therapy. And like Dominique said earlier, while I am a doctor, I am not your doctor today. So everything that I'm sharing today is just for information purposes. It should not replace your physician's advice. If you have specific questions about your health, please contact your doctor. But I'm happy to provide any general education about transplantation here today. So our objectives for today will be to basically discuss the disease physiology of sickle cell disease, what causes sickle cell disease, and how can bone marrow transplant help control that. Then we will talk about different kinds of donors and conditioning regimens used for transplant. Like Dominique said, we'll talk about the high intensity and the low intensity transplants. And at the end of the session, I will hope that you'll be able to describe the general risks and benefits of transplant procedure for sickle cell disease. And once again, like I said earlier, I will not be talking about gene therapy today. That will be the topic of the next two classes over the next few weeks. So we'll get started. If you have any questions, please write them down or put them in the chat as I'm speaking, and I will try and get back to all the questions towards the end after the presentation is over. Okay, so before we start talking about bone marrow transplantation, I just briefly want to talk about sickle cell disease and what causes sickle cell disease. I think many of you probably already know that, but just to bring everybody to the same page, I'm going to briefly cover that. So, as you all know, our body is made up of millions and millions of cells, and inside these cells, we have chromosomes. Now, these chromosomes are basically made up of DNA, and this DNA has a lot of genes on it, and these genes, they code for everything from different proteins to what your hair looks like, what hair color you have, what skin color you have, how tall you are, do you have a long nose, short nose, big eyes, brown eyes, whatever. These genes code for every single thing in your body. So, if you had to compare these genes and cells to things that we are more commonly aware of in our surroundings, I would say that if your cell is like a book, these chromosomes are like different chapters of that book, and then the genes are different sentences in that chapter. So, in a book, as you have a number of chapters, in a cell, you have a number of chromosomes, and these chromosomes, they are made up of sentences, which are genes. And just like sometimes you can have a spelling mistake in the book, sometimes you can have spelling mistakes in these genes. So, like here, you have a sentence: the gray cat ran down the hall. It can have a spelling mistake, and that spelling mistake can change hall to a ball. Now, the gray cat ran down the ball, it's also a sentence, but it's not the right sentence. And this is what happens in sickle cell disease. So, in sickle cell disease, you have all the blood cells, and on chromosome number 11, in the HBB gene, which codes for beta globin, which is a part of the hemoglobin, you have a spelling mistake, which causes sickle cell disease. All right. So I'm going to make it a little complicated now, and just to make sure that we are talking in more scientific terms. So, like here, you have these different different genes on chromosome number 11. Um, in purple, I have shown two fetal genes which produce fetal hemoglobin, HPG1 and HPG2. These are produced when we are in our mother's womb, and somehow something happens around the time of birth, and these genes get turned off, and the adult genes, which are shown in green over here, HBB and HBD, they get activated. And HBB, as I mentioned, is the gene which codes for beta globin, which is a part of hemoglobin, and that's where there is a spelling mistake. So instead of GAG over here, when you have sickle cell disease, there is a GTG. Now, this codes for different proteins. And so in the beta globin molecule, instead of glutamic acid, you have a valine. And what that does is, normally hemoglobin molecules should look like this. They should be independent of each other inside the red blood cell, and they help carry oxygen. But when somebody has sickle cell disease because of this spelling mistake, these molecules, as soon as they lose oxygen, they form long chains with each other. These are called polymers. And these chains of hemoglobin are responsible for the long, elongated sickle shape or C shape of the red blood cells. So when there is less oxygen, these cells become C shaped. So once again, this is what normal blood cells should look like. Normal blood cells, they look like flat discs, like frisbees. They have a dimple in between. And when somebody has sickle cell disease, blood cells look like this. They look like a sickle, like C-shaped. And these blood cells, they break down easily, something that we call hemolysis. So people with sickle cell disease have less blood cells, and that leads to anemia. So your hemoglobin is low, the cells break down easily, and these sickle shaped blood cells, they block blood vessels. So normally, as you can see on the left side, blood cells should be able to flow easily through different blood vessels. But when you have sickle cell disease, these blood cells, they're hard, they are stiff, so when they pass through small blood vessels, they get stuck. And as you can imagine, blood flows through all parts of the body. Blood flows through the brain, the heart, the lungs, the kidneys. So even though sickle cell disease is indeed a blood disorder, it really affects every single organ system in the body. So in infancy, when you're a child, sickle cell disease can affect the brain and cause a stroke and can cause splenic sequestration. As children get older, they start having pain crises because these blood cells, they block blood vessels in the bones and muscles. Sometimes this leads to bone death, also known as osteonecrosis. It can also cause kidney injury, nephropathy, eye injury, retinopathy. And as individuals get older, it starts affecting their lungs, their heart, their brain, and literally every organ of their body. Now, one of the things I would like to point out here is that some of these things, like stroke, like bone death, or kidney damage, or heart damage, these things are irreversible. So once this damage happens, we can't fix it. It's done. It's done for the rest of the life. And so, really, what we try to do in sickle cell disease is to prevent this damage from happening so that we don't get to the point where irreversible damage has happened. Now, you know this better than I do, that there are a number of treatments available to treat sickle cell disease. We have known that we can use blood transfusions since a long time. When we give somebody a blood transfusion, we literally replace their sickle blood with normal blood from a donor. So that's how it reduces the amount of sickle blood and reduces complications of sickle cell disease. Hydroxyurea has also been around since the 1990s. In 2017, it was approved for children. And hydroxyurea increases fetal hemoglobin. Those red blood cells that have high fetal hemoglobin, they sickle less, and so they cause less complications, and individuals have relatively better life and less complications. And then over the last few years, a number of other drugs like L-glutamine, crizanlizumab, and voxelotor were also approved by the FDA. And these medicines, they work by different mechanisms. Some reduce pain, some increase hemoglobin, and overall, they reduce the complications of sickle cell disease. Um, but there is a problem with all of them. None of these medicines are curative. So, none of these medicines um, can fix sickle cell disease for good. These medicines need to be taken on a fairly regular basis. Hydroxyurea, as you know, needs to be taken every day. Crizanlizumab is a once a month injection. So, these medicines need to be taken regularly for the rest of your life for these to work. The other problem is that not all of these medicines work the same for everybody. Hydroxyurea may work for some people, it may not work for others. Likewise, crizanlizumab or voxelotor, they may work for some but not for others. And so we've all tried to figure out what can we do to fix sickle cell disease once and for all and not have to worry about it at all. And so, bone marrow transplant for sickle cell disease was actually developed way back in 1983, more than 35 years ago, as a treatment for sickle cell disease. And I'll talk about that in a little bit. And hopefully, gene therapy for sickle cell disease will be approved this year. But today we'll talk about bone marrow transplantation. So, at my institution at St. Jude Children's Research Hospital in Memphis, Tennessee, in 1983, there was a young girl who's shown on the right side over here, Kim George Wilson. She was, I think, about 12, 13 years old back then. And she had sickle cell disease, but she also had leukemia. So Dr. Johnson and his team, they did a bone marrow transplant for this young girl um, to treat her of her leukemia. And when she recovered from her transplant, she did not have sickle cell disease either. So this is how they found out that bone marrow transplant can be used to treat patients with sickle cell disease. This is a picture of Kim George Wilson with Dr. Jane Hankins, who is a hematology doctor here at St. Jude, taken a couple of years ago. So, how do we do transplant? So, here's a patient with sickle cell disease who's getting a blood transfusion. And on the right side, this is what their blood looks like. So the first thing that we do to do a transplant is that we have to find a donor. Now, a donor is a person who does not have sickle cell disease, but genetically looks as similar to this patient with sickle cell disease as possible. So there is something called HLA. So we do HLA matching for donors, and the best donor is someone who has the same HLA type as a patient. So let's say we found a donor. The next thing we do is to harvest bone marrow cells from this donor. There are different ways to harvest bone marrow cells. There's one way in which we put the donor to sleep, and then we put needles in their hip bone and suck out bone marrow from the hip bone. There is another method in which we give the donor injections of a medicine called GCSF, and it causes the stem cells, the blood cells which produce all blood cells, they come out from their bones into the circulation, and then we can collect them by a process called apheresis, which looks very similar to exchange transfusion. So the first thing we do is we harvest bone marrow stem cells from this donor. Now, once we have harvested stem cells, the next thing we have to do is to get rid of the sickle cells. And believe it or not, even today, the best way to get rid of sickle cells from the bone marrow of people with sickle cell disease is to use chemotherapy. Now, chemotherapy is something that we use to kill leukemia cells, but chemotherapy is also very good at killing stem cells, blood stem cells. So we use different chemotherapy medicines to kill these stem cells, which are making sickle cells. And so once we do that, the bone marrow of a patient with sickle cell disease becomes empty. And when that happens, a sickle cell patient, they will not be able to make any new blood cells. And so now we take these harvested stem cells from the donor and put them into the patient, and we wait. And as the days go by, after a few weeks, these stem cells from the donor, they start growing in the patient, and they start making normal blood cells just like the donor. And now the sickle cell disease patient does not have sickle cell disease anymore. So we basically take stem cells from a person and put them into a patient, and that's how we change their blood, and make sure that they don't have sickle cells. Okay, now this sounds very easy, but of course, if this was easy, we would be doing it every single day. So there are some problems. Well, first of all, who is the best donor? So I told you that we try to do HLA matching, and that's a process by which we find the best donor. A fully HLA matched brother or sister who does not have sickle cell disease is the best donor. So if you have four brothers and sisters, the chances are one of them will be a full match. Now, they can't have sickle cell disease, but if they have sickle cell trait, it's okay. We can use donors who have sickle cell trait. The next best donor would be a volunteer donor, somebody who's not related to you, who's not in your family, but still is a full HLA match to you. Now, volunteer donors who are a full HLA match to you are difficult to find. Um, there is a chance that only one out of every five patients who needs a transplant for sickle cell disease will find a fully HLA match donor. And then the last option is to find a half match relative, who is not a full match, who's a half match. And usually, parents and siblings or cousins are at least half a match. Parents are always half a match, but some siblings and cousins can also be at least half a match. So these are the three main options. Um, Now, as I was saying earlier, transplantation is one of the most intense treatments for sickle cell disease. As I mentioned earlier, transplantation requires high dose of chemotherapy. Sometimes we also have to use X-rays or radiation. And these things, both chemotherapy and radiation, can induce irreversible organ damage. So they can damage the heart, the lungs, the kidneys, pancreas, and thyroid even more. So I told you earlier that sickle cell disease already causes damage to these organs. And then when we use this high dose chemotherapy, that can cause even more damage to these organs. So much so that myeloablative conditioning or high dose treatment, high dose transplants, which I will talk about in detail in a little bit, as well as reduced intensity transplant. So, where the dose of chemotherapy has been reduced a little bit, they are associated with about a 10% risk of death. That means that of 10 people who undergo a transplantation for sickle cell disease, one of them could die due to the transplant procedure itself. Now, we are improving our methods of doing transplant, and we are making them safer and safer. And this risk is going down every day. But still, this risk is not zero. There is also a risk of developing graft versus host disease. Graft versus host disease is an immunological complication that can happen after transplant. And in graft versus host disease, what happens is the immune system of the donor that we collect the cells from, it attacks the body of the patient who has received the transplant. And graft versus host disease can be mild. It can present like a little bit of a skin rash or a little bit of nausea or diarrhea, but it can be pretty severe. I have seen patients who have developed ulcers of their skin, who have 5-6 gallons of diarrhea every day. And graft versus host disease can be life threatening too. So graft versus host disease is a major complication that happens about 5 to 20% patients after transplant. We can use medicines to prevent it, but sometimes it still happens despite the use of medications. All right. So now I'm going to show you some numbers. And these are basically studies that have been published over the last several years, discussing these different kinds of transplants. So first we will talk about the very first kind of transplant that was done. Matched sibling donor, like I said, is the best kind of donor, somebody, a brother or a sister, who is a full match to you. And so the very first kind of transplants were done using matched sibling donor, a brother or sister who's a full match, and using high dose chemotherapy. What we see over here is the overall survival and the event free survival. So, the way I have organized these tables is on the left side, I have written who the first author, who was the main author, investigator who did these studies, and what year those studies were published in. So, you can see these studies were published in 1998, 2000, and 2007. Then the next column talks about how many patients were there. So there were about 50 to 87 patients in these studies. This was the age of those patients. So they were young children, most of them 7 to 9 years of age. This was the conditioning regimen that they were using. This was busulfan based. But more importantly, these are the numbers that I want us to focus on. So, in these high dose chemotherapy transplants that were done initially in the 1990s and early 2000s, the overall survival was about 93, 94%. So, what that means is, if 100 people were transplanted, 93 of them were living at the end. So about 6 to 7% patients, similar to about 10%, what I told you earlier, died because of the transplant procedure itself. Now, amongst those who survived, another 10%, their sickle cell disease came back. So the event-free survival, how many patients survived and did not have sickle cell disease, that was about 77 to 82%. So if 10 people got this transplant, one patient would die from the transplant, and one patient, their sickle cell disease would come back. And so only 8 out of 10 would be cured of their sickle cell disease. And then, as you can see in the last few columns over here, about 20% patients developed acute and chronic graft versus host disease. So there was good success, I would say, about 90% success at elimination of sickle cell disease, but that came at a cost of risk of GVHD and of death. Now, when there was so much death happening, we wanted to obviously reduce the number of deaths that were happening, and we wanted to reduce the number of complications. So a number of people developed what we now call reduced intensity conditioning transplant. So what they did was they slowly started reducing the dose of chemotherapy used for doing the transplant. So here are some of the reduced intensity conditioning transplant regimens, which were done mostly in 2010s. And so these studies, as you can see, the overall survival improved. So in a few studies, the overall survival was almost 100%. That means that nobody died in these transplant protocols, though in some other protocols, it was still 93 and 91%. So the risk of death was lower, but it wasn't zero. It improved, but not zero. And then again, the event free survival, as you can see over here, was not 100% either. So once again, if 10 people received this type of transplant, one or less than one person in a study would die, and almost all of them who lived would be cured of their sickle cell disease. But still, many of these patients, as you can see, developed acute and chronic graft versus host disease. So that still remained a problem. And, I think of it this way. I think sickle cell disease is a bad disease anyway, but graft versus host disease is not any better either. So if we end up treating a patient with sickle cell disease and they develop graft versus host disease, that's just converting one bad disease into another bad disease. So these transplant regimens, they came with a risk of death, but then they also converted one bad disease to another bad disease in a number of these individuals, and that's really not ideal. So these transplant regimens, though they are helping cure a number of patients, I think we still need to keep working on them and improving them and making them better. And so when this was going on, people started developing non-myeloablative approaches. So especially a group based in the National Institutes of Health, NIH, in Bethesda, Maryland, they developed a non-myeloablative approach which uses very low dose of radiation or chemotherapy. In fact, this particular regimen did not use any chemotherapy at all. They use a small dose of radiation and they use antibodies. And so, by using no chemotherapy at all in this transplant regimen, they were able to reduce the risk of death to very, very low. Almost no death happened. And there was minimal risk of GVHD. But most patients in their blood ended up having mixed host donor chimerism. What that means is that they had a mixture of their own blood and blood from the donor. Now, that's not a good thing. So, if you have a mixture of your blood and blood from the donor, um, it doesn't sustain very long. One of them wins. So, if a sickle cell disease patient undergoes transplant and has that mixture, and their cells win, their sickle cell disease will come back. But if the donor cells win, that person can develop graft versus host disease. So, in order to prevent that from happening, from preventing sickle cell disease to coming back or from graft versus host disease from happening, we have to immunosuppress these patients. We have to give them a medication for a very, very long time. And sometimes these medications, they lasted almost 3, 4, maybe even 5 years. And these immunosuppressive medications, they suppress your immune system, so they increase the risk of infections. Another problem that happened was that some patients after transplant, they developed leukemia. And so now, even though these transplant, the low intensity non-myeloablative transplant was very good, people didn't die because of transplant, and almost nobody got GVHD. But because people needed to stay on immunosuppression for a very long time, and there was a risk that some people might develop leukemia, this approach has been abandoned. So people are developing all other kinds of non-myeloablative approaches. But when these initial transplants were done, like I said, nobody had GVHD, but very few people died. This transplant, because of the risk of leukemia, now this particular approach using alemtuzumab and low-dose TBI is no longer being pursued, and people are doing different things. Having said that, in younger children, there is a trial which is still ongoing, which is trying this approach. And the good news is that in younger children, this approach still seems to work with no risk of leukemia. But in older individuals, this approach has been abandoned. All right. So, as I told you earlier, all these transplants we talked about, they used a sibling donor, a brother or a sister who's a full match. But I told you earlier that most sickle cell disease patients, they lack a match donor. So less than 14%, almost 1 out of 10 individuals with sickle cell disease will have a brother or sister who's a full match and does not have sickle cell disease. And 1 out of 5 African Americans will have a well matched donor in the registry. But almost everybody has a willing and committed haploidentical donor in the form of a parent or a sibling. And so, with careful selection of patients, we might be able to balance the risk of doing a half matched transplant. And so here I'm showing a number of haploidentical transplants studies that have been published over the last several years. These studies mostly started towards the later half of 2010s, and most of these studies have transplanted small number of patients. And as you can see over here, in some of these studies, um, almost everybody survived, almost 100% survival. Some studies had a little lower survival, but there was a risk of graft rejection. And so, anywhere from um, 50% to 90% people had their graft sustained. So their sickle cell disease didn't come back. And then a number of patients also developed graft versus host disease. As I mentioned earlier, because these are half match transplants, the risk of graft versus host disease is higher after doing a half match transplant. So even though people survived, many of them developed graft versus host disease. And I said earlier, that basically converted one bad disease into another bad disease. So I should mention that, haploidentical transplants, while they have given a number of patients an option, a potentially curative option, it's not a foolproof, sure shot idea. These transplants are still being developed, they're still being improved. in clinical trials and research. And I would urge all of you, if you're considering a transplant, you should participate in a clinical trial so that it not only helps you, but it also helps make transplant better for future patients who might be interested in transplant in 5 years, in 10 years from now. Because every time a patient gets treated on a clinical trial, we learn something more about these transplants. All right. So, to summarize everything that I said, transplantation, it's like a balancing act. So if, let's say, we said these myeloablative transplants were on the top over here, they had the highest intensity, and they were the most toxic, they caused the most side effects. The advantage that they came up with, that very few people rejected this type of transplant because of the transplant intensity. When we talk about these reduced intensity transplants, they reduce the toxicity of transplant, the organ damage, the number of deaths that happen because of transplant. But some patients, they have a mixture of host and donor blood, and they can reject the graft. And the non-myeloablative transplants, they come with the least amount of toxicity, but the risk of graft rejection is very high. And for that reason, individuals need to be on immunosuppressive medications for a very long time. So it's a balancing act. Do you choose high dose transplant, and risk having organ damage and potentially death, but there is low risk of rejection and not many patients have recurrence of their sickle cell disease? Or do you choose something on the other end, where the non-myeloablative transplant? I think that's a balancing act, and it depends upon how much has sickle cell disease already damaged the body, the organs of an individual. If it's an older individual with sickle cell disease, somebody in their late 30s or early 40s, who may have already had heart damage or lung damage or kidney damage from sickle cell disease, they may not be able to tolerate the high dose transplant. So those individuals, we may advocate that they receive a reduced intensity transplant. But if there is a younger individual, let's say a 6 7 year old child, I would say maybe a high intensity, high dose transplant may be a better choice for them. But again, these transplants are all changing, in how we do them. And so that's evolving over time. Now, there are a number of issues with transplantation. First of all, as I mentioned, not everybody can have a donor. Then we talked about graft versus host disease. We talked about graft rejection. Um, Chemotherapy also causes hair loss. People lose their hair a few weeks after getting chemotherapy for transplant. And while this hair loss is temporary, the hair grows back after some time. Hair loss can be pretty devastating for some people. Chemotherapy can also affect your ability to have children the normal way. It causes infertility. And then temporarily, exposure to chemotherapy reduces your immune system. It can increase your risk of developing an infection. And like I said earlier, in some patients, exposure to chemotherapy or undergoing transplant can increase the risk of developing a cancer or leukemia later on, and even can cause death. And so, BMT, even though it's a potentially curative option, it's not without all these risks that come with it. And so, for every time I talk to everybody, any patient who wants to undergo transplantation, it's an individual discussion. And that's why I said at the beginning of this talk, um, I'm providing general information, but you should discuss these options, and what it means for you, what your risk is with your doctor. One other thing I like to tell all my patients is that if your body is like a wall, sickle cell disease is like a hammer. This hammer keeps chipping on this wall slowly every single day. So, whether we realize it or not, sickle cell disease is damaging the organs in patients with sickle cell disease every single day. It's affecting their heart, their lungs, their brain, their kidneys every single day. And while transplantation can take the hammer away, it does not repair the wall. It does not repair the damage that's been done. So if somebody has already had a stroke, transplantation cannot repair stroke. That damage will be done for the rest of their life. And even after transplantation, that damage will persist. Some patients have osteonecrosis, they have damage to their bones, their hip joints. These patients, the hip joint doesn't improve even after transplantation, and they may need more surgeries to take care of these bone problems after transplant. So it's important to understand that some complications of sickle cell disease may not go away after transplant if the damage is irreversible. And then, what are the challenges to a cure? You know, cure is a very heavy word and it gets thrown around a lot. So I wanted to ask, what does a cure actually mean? And I found the answer that it depends on who's asking the question. So if you ask a physician like me, what is a cure for sickle cell disease? I would say, if the patients are surviving and they don't have GVHD, graft versus host disease, and they don't have sickle cell complications, I would say that's a cure. If you ask a hematologist, a sickle cell doctor, they would say that, if you can control symptoms of sickle cell disease and they don't need sickle cell medications like hydroxyurea and they don't need transfusions, that's a cure. And if you ask a researcher, they would say, well, if there is decrease in sickle hemoglobin, if the red blood cells look better, and if the bone marrow looks better, that's a cure. But what does a cure actually mean? We throw around this word all the time. What's a cure? It's a cure. What is a cure? So I'm going to give you two examples, and these are not real patients, but these are very similar to patients that I've taken care of. So there's a 23-year-old boy with sickle cell disease who was getting chronic transfusions for multiple pain crises, and because of these transfusions, he developed antibodies to the red blood cell antigens. So now we could not find blood for him anymore. We could not find donors for him. So he decided to undergo a half match haploidentical transplant about a year ago. Now, since his transplant, he hasn't needed any blood transfusions. He does not have GVHD, no graft versus host disease, but he still has chronic pain. It's getting better. He hasn't gotten admitted to a hospital in a year, but he still comes and sees me in clinic, and he still needs to take his dilaudid every single day. Is he cured? I don't know. I'll leave that question for you. Here's another example. This is an 18-year-old girl with sickle cell disease who was receiving hydroxyurea, but she was having severe life threatening complications. She developed 2 episodes of acute chest syndrome while receiving hydroxyurea. So then she underwent a haploidentical half match transplant about 6 months ago. She has not needed any blood transfusions or hydroxyurea since her transplant. She has not had any pain or acute chest syndrome since her transplant, but she developed acute skin GVHD, graft versus host disease of her skin. And now she has chronic GVHD. And because of this chronic GVHD, she has started losing her hair on her scalp. She's going bald. And it's possible that her hair on her head may never come back. Um, and she is needing immunosuppressive medications, which she needs to take every single day. Is she cured? I don't know the answers to these questions. When I've asked these patients, do they feel cured? They tell me that they feel better, and they tell me that they feel cured. And these are to some extreme examples. I'm not saying that every one of my patients is like this. There are patients that I have who have gotten a transplant and they are living their life out there. I recently had an 8-year-old boy who received a transplant about a year ago. And before he got a transplant, he could not participate in school sports and could not go in the pool. um, he now this summer went into the pool, is enjoying his life, is playing sports in his school, and is doing great. And there are many other patients like him who are doing fantastic. But at the same time, patients like these two that I just mentioned, it always makes me wonder if this is really a cure or not. And I think that depends on the patient. And so we never asked these patients earlier. And I think the answer to what it means to be cured is different for every patient. And that's what matters. So you need to decide what a cure means to you. And and that's what your goal should be. So that's why once again, I think you need to go and talk to your physician about whether transplant is a good option for you or not. And so I'll say that a cure means different things to different people, and we need to make individual assessments. And not everyone might achieve a cure. And so that's why I like to call transplant and gene therapy transformative therapies. These are therapies which will definitely transform your life, hopefully in a good way, but sometimes in bad ways too. So while they may not be truly curative therapies, they definitely are transformative therapies. And so, where do we go from here? We are trying to reduce the toxicity associated with conditioning regimens without compromising on success. So, I'm running a clinical trial right now. There are a number of other clinical trials which are going on, which are trying to reduce the the badness that comes with transplant. We are trying to reduce the burden of post-transplant immunosuppression so that people don't have to take immunosuppressive medications after transplant, and we are trying to reduce the risk of graft versus host disease after transplant. And we are trying so that everybody who needs a transplant has a donor. And at the same time, we and others are trying to improve delivery of this care, and we're trying to educate people so that they can advocate for better transplant and better therapies for themselves. So that's where I think we need to go next. And thank you so much all for attending this lecture, because I think people like you need to speak up and ask for all these things. That's how a change will come. And of course, there are autologous genetic therapies, gene therapy, which is being developed. Once gene therapies are fully developed, hopefully everybody will have access to them, because you can be your own donor. You don't need to find a donor. And with gene therapy, it does not involve any immunological complications. So there is no risk of graft versus host disease. There is no risk of graft rejection. You don't need to be on immunosuppressive medications after that. But gene therapies come with problems as well. They are very, very new, and long term safety of gene therapies needs to be established. We are still doing clinical trials. And as we will talk about in the next 2 weeks, gene therapies can be very dangerous too. Some techniques like fetal hemoglobin induction may not be applicable to all patients. Gene therapy is also technologically very challenging, and it may not be available to every patient everywhere in this world. And last but not the least, the elephant in the room, gene therapy can be very, very, very expensive. Transplantation is expensive in itself. To do a transplant, it costs anywhere from about 100 to $200,000. Gene therapy, just the cost to make gene therapy is about $2 to $3 million. So gene therapy can be extremely expensive, and it remains to be seen if insurance companies will be able to bear that cost or not. So to conclude, I'll say that reduced intensity conditioning based transplantation, they are a new standard of care for patients with severe sickle cell disease. And the new transplant regimens that are being developed right now, they offer a high chance of event-free survival without sickle cell disease, using both matched sibling as well as haploidentical or half matched donors. But we still need to keep doing better, and we need to make transplantation better for patients with sickle cell disease, and those efforts are ongoing. And last but not the least, patient centered and culturally competent educational material is critical to disseminate education about these high risk, high reward therapies. And we have to engage with patients as partners to develop a meaningful cure. That's something that I keep telling all my physician friends, that that's something that is absolutely necessary. We need to talk to the patients and engage with them so that we can develop something which patients want for themselves. So with that, I will stop here. Thank you so much all for your attention and for listening in this lecture. This is my email address. I will try and answer as many questions as I can right now. But if you still have any questions left, please feel free to email me. And this is my Twitter handle, Akshay Sharma MD. I also tweet about sickle cell disease and about treatments of sickle cell disease. So if you're on Twitter, please feel free to follow me, and I look forward to interacting with you there. So, with that, I will stop sharing my slides, and I'll be here for answering any questions.
I'm on mute. Thank you, Dr. Akshay. That was an amazing presentation. Very good. Thank you so much. I learned a lot about BMT, low intensity and high intensity. So, if we have any questions for Dr. Akshay on this comparative technology, please put them in the chat and we're able to ask it. I know a few people wanted to ask some questions that was inside Zoom. So please place your questions inside the chat and then we will ask Dr. Akshay for you. And if you are on joining us from Facebook or YouTube, please also place it inside the chat and we will see it and we'll ask Dr. Akshay those questions. Thank you all so much for joining us. This was a great presentation. Great presentation as always, Dr. Akshay. As
Thank you.
always, we got a lot of comments saying thank you for sharing. We have thank you so much, Dr. Sharma. Thank God for you and your contributions to the sickle cell community. You know what? I said the same thing. I am so happy for Dr. Akshay Sharma. I'm like, he volunteered to teach all of the comparative classes so that you guys will be able to understand it and it's coming from one person. He's just absolutely amazing and have a big heart. So yes, thank you, Dr. Akshay.
Thank
Hand
you.
claps all around.
Thank you so much.
So I'm looking inside Zoom. We don't have any questions inside Zoom. And on Facebook, I looked, I didn't see any questions there either. We do have someone say that they love the Warrior University class. Thank you very much. So, Dr. Akshay, I know that you stated in your presentation that the BMT isn't for everyone and that everyone's idea of a cure is different. So, you said something, I believe it was last week at the class, or maybe it was before the class started, that these classes that we're having, you don't like to say curative therapy, you like to say transformative therapy. Can you elaborate a little bit more why you prefer to call them transformative therapies instead of curative therapies?
Yeah, absolutely. So, like I was saying, cure is a very heavy word. When we say cure, I think most people um, they think about their life will be absolutely normal. They don't have to take any medications. They don't have to go to the hospital ever again, and they'll have no complications whatsoever at all, right? But that's not true. As I just showed you these two examples of two patients that I had, you know, one of them developed complications of of their transplant and developed graft versus host disease. Now they don't have sickle cell disease, but they still have graft versus host disease. And graft versus host disease can be pretty severe. Now, you know, if it is mild and it doesn't affect your day-to-day life very much, then maybe it's okay. But if it is severe, and it causes you to go back to the hospital again and again, that may not be curative, right? We are just converting one bad disease into another bad disease. And that's why I think it's important to recognize that. What does a cure really mean? It's definitely transformative, that you don't have sickle cell disease anymore, but it has transformed into something else. And transformation can be good or bad,
Mhm.
right?
Yeah.
Cure has only positive connotation. And so I think we have to be careful, because I am a transplanter, and while I do this for a living, I don't want to give a false hope to somebody, because I don't have a crystal ball to predict if somebody is going to do well or not, right? If somebody comes to me and thinks that bone marrow transplant is the best treatment out there and it'll fix everything for them, I would say that they don't understand transplant completely. You have to be you have to be honest, and you have to understand that, like everything else in life, transplant comes with a lot of risks. Of course, there is a chance that everything will go fine, but there's also a chance that things could go bad. And that's the risk. It's a high risk, high reward therapy. And I feel like it's important for me to discuss that with the patients, and for them to understand that, so that they know that things could go wrong. So if things happened, I wish things never go wrong for anyone, but if they did, at least the patients would have that satisfaction that they made that decision knowing that. You know what
Yeah,
I'm saying?
I agree. I've always said cure is a huge word, and I know cure for me looks something totally different than a cure for someone else. So we do have questions. One of the questions: if your child only gets 1 or 2 crises a year, would you still suggest the BMT if they're on sickles?
I'm not sure what sicklos is. Is this?
It's a generic. It's a children's version of hydroxyurea.
I see. Okay, thank you.
You're welcome.
So, you know, again, I'm going to answer this question very hypothetically. You should talk to your physician about this, but generally speaking, I would say um, it depends on what those 1 to 2 episodes are, right? So, if somebody is getting an acute chest syndrome that, let's say, requires admission to the ICU, or it's a very severe acute chest syndrome which is life threatening, I would say for that patient, even one episode happening per year is strong enough for them to think about undergoing transplantation. But if somebody has mild pain crisis, and by mild I mean they don't have to go to the hospital, they get a pain crisis but they take medicines at home by mouth and it gets better, then maybe they should continue hydroxyurea or try some other medicines. Again, in the end it's a personal decision. um, some people have come to me and they tell me that, Dr. Sharma, I don't want to take hydroxyurea. I don't want to take medicines for the rest of my life. I want to get this treatment done today. And, if they have a matched sibling donor, a fully matched brother or sister, that's a very different story than somebody who maybe has one mild pain crisis a year. They manage that at home and they don't have a donor. The only donor available for them is a half match donor. Now, half match transplants are higher risk. And so, if they're doing relatively well on hydroxyurea, I would say they should not think about transplant if they don't have a good donor. So, it's a complicated question. And I think it depends on the whole, what is the severity of your disease, how many episodes, what kind of episodes you're having, what kind of donor you have, and so forth and so on.
Thank you. So I actually think you kind of also answered this question. Who said who would be the best candidate for a BMT? My daughter is 5 years old with a hemoglobin of 13. Has never had a crisis. My husband's goal is to be able to have her have a BMT, and she also has epilepsy.
Yeah, so I mean, I think for for somebody who has never had a crisis, you know, it would be hard for me to justify that they should undergo a transplant because, like I said, while the risk of death from transplant is getting down, it's not zero. And and I wouldn't be able to live with myself if I had a child and they were doing fine and I told them that, go through transplant and they did do well if they unfortunately died. you know so I think if somebody is doing well on hydroxyurea and has never had a pain crisis, I think you should wait. And you should, because the reason you should wait is because transplant is evolving, as I said. Things are getting better every year. We are making new transplant regimens, we are reducing the risk. So in 5 years from now, a much better transplant regimen might be available, which will have much reduced risk of complications. And maybe go for that.
Thank you. We have another question. What percentage of transplant patients continue to have pain long term? I read on an NIH article that stated it was somewhere near 40%, up to 40%.
Yeah, to be honest with you, I don't know what the percentage is, but I can tell you that those patients who have much more severe sickle cell disease. So I'll give you an example. I had a patient who was getting admitted almost every other week for a pain crisis. So his sickle cell disease was so bad that almost 15 days in a month he would be admitted to the hospital getting pain medicines. That patient continued to have pain crisis for almost, well, not pain crisis, he continued to have chronic pain for almost 1 year after transplantation. There was another girl that I took care of who also had very severe disease, and she continued to have uh, pain, chronic pain, for almost 6 months after transplant. The reason for this is, for these patients with very severe disease, their nerves are just sensitized to pain. So even if there is no sickling happening in their blood, their nerves still continue to feel that pain and sending those signals to their brain. So so that's the type of chronic pain that can happen, and the resetting of these nerves can take many months to years after transplant.
Oh wow. So even after the transplant, even if it's successful, you still can have pain and
Yeah.
everything. It's a big decision to, if you're doing any one of the transformative therapies to do. Um, I know in one of the comments, one of the people said it's a very scary process, but if they're able to do it, they will still do it. It is, and like you said, it all depends on the person, their condition, what their hemoglobin looks like, what their fetal hemoglobin, like everything, what medication they're taking. And like I know for me, my crisis attacks, I don't have them where I'm hospitalized 4, 5, 6, or 10 times a year. It was a few years ago, it was just 2 times, but those 2 times were extremely bad times. Like they were decreasing but increasing in intensity. And so you just have to, everyone is a personal decision when it comes down to that.
Yeah, for sure. And the most important of all these factors is, what do you want, right? Because I can tell you, some people have a high risk tolerance. I give my patients an example. You know, people go skydiving. They jump from a perfectly flying airplane, right? Some people love skydiving. Other people, like myself, I will never jump from a perfectly normal flying airplane. So the risk tolerance can be different, right?
True.
So
Yes.
what do you really want, and what is your risk tolerance is a big factor for deciding what is best for you. I can't tell you what you want. Like Dominique, you said, I think you need to make that decision. It is your life. And whether transplant works or doesn't work for you, ultimately you will be living that life. So what choices do you want to make is something that you need to discuss with your physician, and your physician can help you make that decision. Just like Dominique said, how many sickle cell events you've had in a year, what medications you are on, how severe those events are, whether you have a donor or not. Your physician can help answer all those questions for you, and then based on those questions, based on that information, you can make the decision.
So one of the things you stated was that the best way to go about doing a bone marrow transplant is doing a clinical trial. And so one of the questions was, where can they go to find a clinical trial on bone marrow transplant?
Right. So there are two ways to do this. One is, you can obviously ask your doctor, and your doctor can refer you to a transplant center. And most transplant centers will know what trials are open and where. The other option is to go to a website called clinicaltrials.gov, www.clinicaltrials.gov. And if you go to that website, it's a government website, and it lists every clinical trial that's running in the US and some other countries also. And it can provide that information. So if you allow me to share my screen again, I'll show you how to find it.
Yep, you should have access to share your screen.
Okay, all
And
right.
I will put inside the chat the website, clinicaltrials.gov.
Okay, so here I'm sharing my screen again. So you'll go to www. dot clinicaltrials.gov. And so this is what this website looks like. And so here
You're
you,
not sharing your screen yet.
I'm not, oh, sorry.
There we go.
Okay. So this is what the website looks like. And you go type sickle cell disease, and then you type transplant. Okay. And then you hit search. And so when you do this, you will see all these trials that are going on, and it'll tell you what is the name of the trial. And this trial, like it says, completed. So this trial has closed. This trial says recruiting, this one over here. So this trial is ongoing. So let's say I want to read more about it. So I'll click on this, and it'll tell me uh, where this trial is going on. So there is this trial, it's called haploidentical transplantation with pre-transplant immunosuppressive therapy for patients with sickle cell disease. It's going on at City of Hope Medical Center. It'll tell you what medicines they are using, how many patients they will be recruiting, when they are expecting that this trial will close. And if you want to get more information, at the bottom, it will give you who to contact. So to participate in this trial, you contact this person, their phone number and their email address is here. Um, so like that, like, let's say there is this other clinical trial over here. So it says recruiting. So this is an ongoing trial. So you click on this, it'll open this trial. That's the name of this trial on the top. It's going on at University of Illinois at Chicago. Again, it'll tell you what medicines are given on this trial. It'll tell you that they will recruit 15 participants. They estimated that this trial would have completed in 22, but probably still ongoing. That's why they haven't closed it yet. And then at the bottom, if you scroll down, these are the people that you should contact, their phone numbers and their email addresses. So this is a good website for you to go. It's called clinicaltrials.gov. This is what it looks like. And in this here, you type sickle cell disease, and here you type transplant. Likewise, if you want to search for gene therapy, you can do that. So you type gene therapy and you click search, and it'll tell you where any gene therapy trials are going on. So, like this one is only enrolling by invitation. This one is not recruiting. This one is active but not recruiting. This one is recruiting. So, you go here, you click on this, and then you find out, okay, this is the name of the trial. This is where it's going on. And if you want more information about this gene therapy trial, the person you need to contact is here. So these are all the institutions where this trial is ongoing, and who do you contact? So their phone numbers, their email addresses, everything is here. So this is a very good website. You can go here and search for yourself. It can be a little intimidating because it's a very, very busy website. Even for gene therapy, you can have 46 studies that are listed over here. For transplant, there are way over. So I think the best thing I would say is to contact your doctor and they can refer you. But if you want to search for yourself, you can search on this website yourself.
Yes, and one of the questions was that it was only youth only. So when you go onto the website, you have the search bar. You could put in adults. So it doesn't have to just be youth. You can look up and see if there's any clinical trials going on for adults or the age group specific that you're looking for as well. I think of that. I'm going to check the Zoom chat one more time. And I think that is all the questions we have. Dr. Ache, once again, you are absolutely amazing. Great presentation. Thank you all so much for joining us. And we are coming back next week for comparative Technology 2. And I believe it's CRISPR Therapeutics.
No,
correct?
viral vectors.
Oh, yes. There we go. So please join us next week for Curative Therapies, Comparative Technologies 2 with Dr. Akshay Sharma. Thank you so much, Dr. Akshay. Thank you to our participants, those that are sitting on Zoom, those that are on YouTube, and those that are on Facebook. Thank you guys so much for joining us at this Warrior University class, and we'll see you next Thursday at 7 p.m. Eastern.
Thank you.
Thank you. Bye, Dr. Akshay. Bye, everyone.
Bye.